Welcome to our second video on infections of the eyes and ears. Let's begin. In this lecture, we'll discuss acute dacryocystitis and keratitis. Let's start with acute dacryocystitis. Here's the overview slide of the topics we're going to discuss for acute dacryocystitis. Acute dacryocystitis is an acute infection of the lacrimal sac. Before we go any further, let's remind ourselves where the lacrimal sac is. Here you see the anatomy of the lacrimal apparatus. You can appreciate that the lacrimal sac is the sac-like structure located at the medial side of the eye. Eye secretions accumulate in the lacrimal sac and slowly drain into the nasolacrimal duct. As we mentioned on the previous slide, infection of the lacrimal sac is called acute dacryocystitis. Let's briefly review the pathophysiology of acute dacryocystitis. First, there is a blockage of the nasolacrimal duct. As we saw on the previous slide, the nasolacrimal duct drains eye secretions from the lacrimal sac into the nasal cavity. Blockage of the nasolacrimal duct will result in an inability to clear the eye secretions from the lacrimal sac. Therefore, there will be bacterial overgrowth in the lacrimal sac, causing acute dacryocystitis. Acute dacryocystitis is most commonly caused by Staphylococcus species. However, it can also be caused by Streptococcus pneumonia and Haemophilus influenza. Acute dacryocystitis presents with fever and an erythematous, swollen, and painful nodule next to the medial canthus. Additionally, the patient may have purulent eye discharge. This is what acute dacryocystitis looks like. Please note this swollen and red nodule at the medial side of the eye that is consistent with an inflamed lacrimal sac. Acute dacryocystitis can be followed by severe complications like sinusitis due to contiguous spread of bacteria from the lacrimal sac to the paranasal sinuses. Contiguous bacterial spread can also lead to orbital or preseptal cellulitis following acute dacryocystitis. Additionally, accumulation of pus anterior to the eye can result in corneal edema, ulceration, and permanent vision loss. Diagnosis of acute dacryocystitis is mostly clinical based on the patient history and physical exam findings. The characteristic physical exam finding is expression of pus from the eye upon manual pressure on an inflamed lacrimal sac. Imaging studies, like CT, can be done to exclude complications such as sinusitis, orbital cellulitis, or preseptal cellulitis. The dye disappearance test can also support the diagnosis of acute dacryocystitis. However, this test checks for an obstruction in the lacrimal apparatus. Therefore, it is not specific for acute dacryocystitis. Let's discuss the dye disappearance test on the next slide. To start the test, the fluorescein dye is instilled into the patient's eye. Normally, the dye should completely drain from the eye to the nasal cavity through the nasolacrimal duct in 5 minutes. In patients without obstruction of the lacrimal apparatus, a cotton swab of the nasal cavity will reveal color change of cotton. That confirms appropriate drainage of the dye. In contrast, if the patient has acute dacryocystitis or any other condition obstructing the lacrimal apparatus, the dye will be retained in the eye after 5 minutes. The management of acute dacryocystitis depends on the presence of complications like orbital cellulitis. Acute dacryocystitis without orbital cellulitis is usually treated with oral antibiotics like amoxicillin clavulanate. In contrast, acute dacryocystitis with orbital cellulitis requires IV antibiotics such as ceftriaxone or vancomycin. Chronic dacryocystitis is usually treated with a surgical procedure called a dacryocystorhinostomy. This is because chronic dacryocystitis is most commonly caused by nasolacrimal duct obstruction. Dacryocystorhinostomy is a procedure which surgically creates a new passage between the lacrimal sac and the nasal cavity, allowing for normal drainage of tears. Additionally, steroid drops can be considered in cases of chronic dacryocystitis. A 25-year-old woman presents to the physician with a painful, progressively enlarging bump on her right eye that she first noticed 2 days ago. The physical exam shows purulent discharge from the right eye along with an erythematous, swollen, and tender nodule next to the right medial canthus. There is no proptosis, ophthalmoplegia, or erythema around the eyelids. The patient is afebrile. What is the best treatment option for this patient? This patient presents with purulent discharge from the right eye along with an erythematous, swollen, and tender nodule next to the right medial canthus. This description suggests the diagnosis of acute dacryocystitis. Since there is no proptosis, ophthalmoplegia, or erythema around the eyelids, this patient has acute, uncomplicated dacryocystitis. The best treatment option for acute, uncomplicated dacryocystitis is oral antibiotics such as amoxicillin clavulanate. Let's move on to keratitis. Here's the overview slide of the topics we're going to discuss for keratitis. Keratitis is an inflammation of the cornea. It can be both non-infectious and infectious. In this lecture, however, we will only talk about infectious keratitis. Let's revisit this slide briefly before we discuss keratitis. As you can see, the cornea is the thin, transparent layer anterior to the pupil. Inflammation of this layer is called keratitis. Let's talk about risk factors for keratitis. First, penetrating or blunt ocular trauma can introduce bacteria into the cornea, causing keratitis. Additionally, wearing contact lenses predisposes the patients to infectious keratitis because bacteria like Pseudomonas aeruginosa can overgrow in contact lens solution. We will talk more about the infectious causes of keratitis on the next slide. But before that, it's worth mentioning that chronic use of corticosteroid eye drops can cause thinning of the cornea, facilitating bacterial introduction into the cornea. Keratitis can be caused by a variety of microbes. Bacterial keratitis is commonly caused by Pseudomonas aeruginosa and Staphylococcus aureus. Keratitis due to Pseudomonas aeruginosa is particularly common in contact lens wearers due to the reason explained on the previous slide. Viral keratitis is most commonly presumed to be caused by herpes simplex virus. Candida and Aspergillus are implicated in fungal keratitis. Finally, parasitic keratitis is most commonly caused by Acanthamoeba. Acanthamoeba keratitis is also most prevalent in contact lens wearers. The clinical presentation of keratitis is mostly nonspecific and includes diffuse conjunctival injection, eye discharge and pain, and fever. The patient may also complain of a sensation that they have a foreign body in their eye. Corneal clouding or ulceration may be more indicative of keratitis than the other eye infections that we have previously discussed in this lecture. Here you see a photo of a patient with keratitis. Please note the diffuse conjunctival injection evidenced by dilated conjunctival vessels. You can also appreciate this cloudy cornea with decreased transparency. The cloudiness of the cornea is also known as a hypopyon and represents accumulation of suppurative materials in the anterior chamber of the eye. The diagnosis of keratitis is primarily based on history and physical exam findings that we have discussed on previous slides, such as eye pain, discharge, conjunctival injection, and corneal clouding. On physical exam, the infiltrate can typically be seen without the use of a slit lamp examination. However, on slit lamp examination, corneal ulcerations or abrasions can be more easily identified. These will stain with fluorescein if used. Here you see the slit lamp exam of the patient with keratitis. Please note this corneal abrasion accentuated by fluorescent dye. A 41-year-old man presents to the physician with severe right-sided eye pain for the past 4 days. He has myopia treated with contact lenses. The physical exam shows a right-sided clouded cornea with diffuse conjunctival injection. The slit lamp exam reveals linear corneal abrasions. Which class of antimicrobial agents is preferred for this patient's current symptoms? This patient presents with severe eye pain, a cloudy cornea, and diffuse conjunctival injection. The slit lamp exam reveals linear corneal abrasions. These findings suggest a diagnosis of keratitis. Since he wears contact lenses, the most likely cause of keratitis in this patient is Pseudomonas aeruginosa. The preferred class of antimicrobial agents for patients with suspected Pseudomonas keratitis is fluoroquinolones. This patient needs topical fluoroquinolone eye drops. As we just saw in our practice question, the management of infectious keratitis depends on the type of microorganism responsible for corneal infection. Bacterial keratitis is treated with antibiotics like cephalosporins, macrolides, and fluoroquinolones. As seen in the question, fluoroquinolones are preferred in contact lens wearers with suspected Pseudomonas keratitis because these antibiotics cover Pseudomonas well. Viral keratitis is treated with antivirals such as acyclovir with or without steroid eye drop. Fungal keratitis is most commonly treated with topical amphotericin B or fluconazole. Finally, parasitic keratitis is treated with topical miconazole or metronidazole with or without steroid eye drops. A 12-year-old girl is brought to the physician by her parents due to a red and painful eye for the past 3 days. She's a leader of a school swimming team. Her vital signs include a temperature of 37 degrees Celsius, blood pressure of 100/70, heart rate of 82, and respiratory rate of 14. Physical exam reveals right-sided corneal opacity and conjunctival injection along with purulent discharge. There is no proptosis, ophthalmoplegia, or erythema around the eyelids. Which of the following is the best next step in the management of this patient? A. Eye irrigation. B. Slit lamp exam. C. Eye patch. Or D. Prednisolone eye drops. This young girl presents with a red and painful eye for the past 3 days. She's a leader of a school swimming team, which raises suspicion of a waterborne eye infection. The physical exam reveals right-sided corneal opacity and conjunctival injection along with purulent discharge. These findings suggest the possible diagnosis of keratitis or conjunctivitis. There is no proptosis, ophthalmoplegia, or erythema around the eyelids, making orbital and preseptal cellulitis unlikely. In order to distinguish keratitis from conjunctivitis, one should perform a slit lamp exam. Slit lamp exam will reveal corneal abrasions in cases of keratitis, while it will be unremarkable in the setting of conjunctivitis. Therefore, the correct answer is option B. Here's a slide reminding us of the diagnosis of keratitis. Let's discuss why other options are incorrect. Option A and C are incorrect because eye irrigation and eye patches are not helpful for treating keratitis. Finally, option D is incorrect because although prednisolone eye drops may be prescribed to treat keratitis, the patient needs to be diagnosed first. Additionally, steroid eye drops are usually not prescribed without antibiotics for the management of keratitis. And that concludes our lecture on acute dacryocystitis and keratitis.